Hello everyone, and thank you for joining us for today's webinar, Putting Patients First, New Opinion Research and Messaging on When Religious Beliefs Override Patient Care. My name is Yumhee Park, and I'm the Engagement and Mobilization Associate at the National Women's Law Center and today's moderator. We have a few technical notes before we begin. First, all lines will be on mute during today's webinar. Second, we'll be taking questions after our speakers are finished with the presentation, but we encourage all of you to submit questions throughout the webinar. You can submit a question by typing it using the chat function. Finally, this webinar will be recorded, and you will receive a link to the recording of the presentation as well as a link to the slides and other materials within the next few days. At this point, I'd like to turn the floor over to Gretchen Borchardt, Vice President for Reproductive Rights and Health at the National Women's Law Center.
Thanks, Yumhee. Hi, everybody. Welcome to our webinar. As Yumhee said, it is called Putting Patients First, New Opinion Research and Messaging on When Religious Beliefs Override Patient Care. And we want to welcome all of you, and thank you for joining us today. So as Yumhee said, I'm Gretchen Borchardt. I'm the Vice President for Reproductive Rights and Health at the National Women's Law Center. And we were really thrilled to see the overwhelming response we got to this webinar. We had over 150 people register for it. And I think that shows that there's just a real desire to understand how religious exemption laws harm patient access to care, what the public thinks about them, and how we can push forward proactive policies that address the problem. And so I'm really excited to let you all know that this webinar is going to give you all of that information. So what I thought I would do is spend a few minutes giving a little bit of context and overview for our panel today. And in doing so, I'm going to introduce each of our panelists and let you know what they're going to talk about for the webinar. And I want to start first by introducing the National Women's Law Center. For those of you who don't know us, the National Women's Law Center has been working for more than 40 years to expand and protect and promote opportunity and advancement for women and girls at every stage of their lives. So at school, at work, at home, in their communities, in retirement, wherever they are, we're here for them. And our work takes many forms. So we work with state and federal legislators. We work to make sure that laws that are passed are enforced properly. We work to advance our legal positions in courts. And we also conduct campaigns and public awareness efforts to educate and mobilize the public to press for the policy changes that improve women's lives. And we have long used these different strategies around the issue of religious refusals to provide reproductive health care, specifically abortion or birth control or medical care for a miscarriage. And the reason we have a long history of working on this is because this has long been an issue. So we know that the first federal religious exemption law passed shortly after Roe versus Wade. So almost as soon as the Supreme Court gave us and affirmed the right to decide whether to have an abortion, Congress actually decided to allow some providers to use their religious beliefs to override that right. And that original federal religious exemption law has now been joined by others from Congress. One of the most recent is the Weldon Amendment, which not only allows health insurance plans to refuse to cover abortion, but also allows providers to refuse to give a woman a referral for abortion. And what we've seen happening at the federal level has been echoed and even intensified at the state level. Well, now almost every state has a religious exemption law. And I just want to be clear what we're talking about when we say religious exemption laws for purposes of the survey and the discussion today are laws that allow healthcare providers like hospitals or doctors, nurses, clinics, health insurance companies to refuse to treat a woman seeking an abortion, birth control, or medical care for a miscarriage. There are other kinds of religious exemption laws that reach other types of things, equally problematic, but for the purposes of today's discussion, this is the kind of religious exemption law we're talking about and that we looked at in our survey. Now, we know that these laws have real consequences for women, and these refusals have real consequences for women. We have seen that time and time again. So we have seen these laws embolden abortion opponents to cite religion as a way to deny care to women. We've seen women turned away at a hospital when suffering a pregnancy loss. We have seen providers refuse to give women the referral or information she needs about her condition. And so we're really lucky to be joined today on the webinar by Faith Grusbeck, who is with us today from Muskegon, Michigan. She is a patient advocate and community organizer who has over 18 years of experience in education in maternal and infant health. She's also a certified birth doula and certified cooperative childbirth educator, and she serves on the Muskegon County Sexual and Domestic Violence Task Force, among other community organizations. And so Faith is going to talk about her firsthand experience of working with women who are denied care because of religious refusals. And she's going to talk about the reality of living in an area where religion dictates patient care. Now, we know that harm has been happening, and somehow that message was not really breaking through. We saw that using religion to discriminate was breaking through in other areas like LGBTQ issues, as it should have and was great, but on abortion and other reproductive health care, it seemed as though many were just accepting these laws as status quo and saying, well, yes, of course religion can override patient access to care when it comes to abortion, but that is not right. That should not be the case. A woman should be able to trust that her provider is going to give her the care and information she needs based on her health and her circumstances, not based on religious beliefs. So that is what brought us to the idea of doing this polling and this survey, to push back on the status quo, to show that these religious exemption laws are harmful and that they should not stand. And we felt sure that if the public understood the harm and understood these laws, that they would agree with us. And the good news is that we were right. And so we have today Anna Greenberg here with us. We're thrilled to have Anna. She's a partner with Greenberg, Quinlan, Rosner Research. She has over 15 years experience polling in political, nonprofit, and academic sectors. And we were thrilled to work with Anna and her team to develop and conduct this survey. And so in the webinar today, she's going to walk you through the results of the survey and the really important results showing that the public does not support religious exemption laws. And we feel like this research is even more important now, needed even more now. It's so much more urgent now that we have a new administration, a new Congress that has already made clear both that women's health is a target and that they're going to prioritize religious freedom. And I put that in quotes, it's their view of religious freedom, that they're going to prioritize that above everything else. And we really only have to look back a couple of weeks to know that that's true, right? 2 weeks ago today, the House of Representatives passed a bill that would effectively end private insurance coverage of abortion, would defund Planned Parenthood, do a host of terrible things for women's health. And that very same day, the president signed an executive order that's the first step in letting bosses take insurance coverage of birth control away from women under the guise of religion. And we know that there are continuing attacks at the state level, too. It's not just what we're seeing at the federal level. So this work, this research, is really preparing us for the inevitable fights that we have ahead, whether it's things we've already seen and know are still kicking around, efforts that we know that they keep reintroducing and trying to push, or whether there's going to be new stuff coming down the pike at us. We're ready to push back hard, and the research shows that the public is going to support that. But doing that defensive work is not all we want to do. It's not the end of the story. We can't just be in a defensive posture, right? We want lawmakers to stand up for policies that protect patient access to care. We want to make sure that they're standing up for policies that make sure healthcare providers are giving patients the right care for their situation, and that includes abortion. And the encouraging news is that, especially in the states, there are policymakers that are already stepping up to do that. And we're lucky to have on this webinar today Bridget Amiri, who is Senior Staff Attorney with the ACLU Reproductive Freedom Project. She's going to talk more about some proactive efforts in the legislatures in the states, through litigation, ways to push forward and take back the problem of refusals and redefine what it means to be discriminated against in the context of healthcare. So that is the overview. That's what we're going to be doing today. As Yemhi said, we will have time for questions and comments at the end, and we look forward to a robust discussion. But we're going to start with Anna giving the results of the survey, then hear from Faith, and then Bridget, and look forward to hearing from all of you at the end. So with that, I will turn it over to Anna.
I almost forgot to take myself off mute. Thank you very much. Happy to be here today and talk to you about the results of the survey research that we've conducted for the National Women's Law Center focused on the issues of religious refusals. And as Gretchen mentioned, the results are very encouraging, both in the sense of how people feel about the issue on its own, but also in exploring messaging that actually sort of moves the needle and educates people about the challenges to women's health care and access to women's health care that are created by these religious refusals. Just to give you a little bit of detail about what we did here, we conducted a national survey of 1,650 registered voters. The total sample included oversamples in certain states and among certain demographic groups. We conducted this research in March, 45% on cell phones. I'd also add that we conducted a round of focus group research late last year as well, and that informed the creation of the survey research. So just to start, I mean, overall, we ask a basic question about whether or not health insurance plans should cover all basic health services. And I just want you to note, if you look at the question wording, we have birth control and prenatal care and childbirth and postpartum care, but we also have abortion in the definition of all basic health services for women. And I think you can see that the support is fairly overwhelming. 64% of people agree that insurance companies should cover these basic health services. Notably, 50% believe that strongly. So there's real intensity and to the belief that insurance companies should cover these basic services. I would argue that that potentially has even more resonance now with the Republican health care plan that passed that eviscerates essential benefits. We don't know what the Senate will do, but the notion that there are some just basic aspects of women's health and reproductive health that need to be covered by insurance companies, I believe that that sentiment may become even stronger. When we ask people specifically about the religious exemption issue, people lean against religious exemptions. And I want you just to keep in mind that this is a somewhat complicated issue for people to understand, and I think that the way that most people know about it, and this is what we heard in the focus groups, was people know something about Hobby Lobby. But in general, you know, things like the Weldon Amendment and other kinds of religious exemptions are not really well known, and part of the reason why we're able to actually move people to a place of greater opposition to them is that, frankly, by just literally providing them information about what it means for women's access to health care. But nevertheless, what you see here is that, you know, with a very basic description of the religious exemption laws, and you can read the question wording, and you can see that we include abortion in the question wording here, that 49% of people oppose conscience clauses or religious refusals. Not quite a majority. I am encouraged, by the way, that there is more strong opposition than there is strong support. So we have people at the very beginning without really any information except what's in the question wording, leaning against religious exemption laws. When we then talk about some very specific consequences, things that might happen if we allow, in this case, you know, we expand the range of entities that we are talking about here. So in the earlier question we had two slides ago, we talked about insurance companies, but the whole question of different healthcare entities is important here, and people do make some distinctions, though ultimately where people come in the end is if they're against religious exemptions, it applies to sort of everybody. So the different entities we looked at and talked about in the groups and tested in the survey were, not surprisingly, insurance companies, but also hospitals, and then individual providers, doctors and nurses. And like I said, even though you can see that there is some difference here in sort of people's view of these different consequences, where you can see insurance companies and hospitals are sort of at the top and doctors and nurses are sort of down at the bottom. But nevertheless, we still have, in general, a resistance to all these different healthcare entities, you know, if these laws were adopted or as they are adopted, what happens. And so you can see we're refusing to cover abortion, birth control, or medical care for a miscarriage because of religious or moral beliefs. And in the focus groups, I mean, people were able to, you know, talk about more in the context of hospitals, but they were actually able to draw upon having either people they knew or family who had actually were in the process of having miscarriage and sent home from a Catholic hospital. And so people were not, it wasn't unbelievable to them that that could happen. People believed that could happen. The other thing that people really reacted to was the notion of not giving people information or referrals. In some ways, that was the most outrageous piece to this for people, was that, okay, fine, maybe we should accept that a certain provider, whether it's a hospital or an individual healthcare provider, should have the option of not, you know, providing a service like an abortion, but they should at least be able to give people information about what their options are, or at least give them a referral to go someplace else to get the treatment they need. The idea that you wouldn't even give people information was really outrageous to people. And it leads into really what the title of this webinar is, and where the messaging takes us is that people think that patient care should come first, and that what people need to be taken care of should take priority over either the institution's religious or moral beliefs or the individual provider's religious or moral beliefs, which is a segue into the next slide. So we tested actually a lot of messages, and I can tell you kind of what did well and what did not do well, but you can see here that sort of the top message, and it's really kind of the top two, they tested fairly similar to each other, was the idea that patients' health should always come first. And so the idea that the individual religious or moral beliefs of any entity, whether it be it the insurance company or hospital or provider, would get in the way of the care a patient receives is people are obviously outraged by. And then when you look at the message that's right below that it risks women's health or life, the idea that turning women away on abortion, and you can see we more specifically called abortion on the second message, even when the woman's life is in jeopardy, refusing to treat whose miscarriages. And again, we had people in the groups talking about that before we even talked about the message. The notion that it can, infertility, infection, and even death. And people talked about the Hippocratic Oath. I mean, they talked about the notion that, that individual doctors and health providers have an oath to kind of put patients' health and care first, and the idea that that would be overridden by whatever particular religious or moral beliefs. And it also taps into kind of a separation of church and state, sort of the notion that the idea that, and this goes into third message, the idea that in any entity like hospitals that receives any taxpayer dollar would be able to use religious beliefs as a reason to refuse or treat a patient also seemed like anathema. So not only are individual religious and moral beliefs standing in the way of patient care, but you have instances where taxpayer dollars are kind of complicit in that if they go to these kinds of hospitals. And these arguments were very strong. In fact, when we tested and we looked at this question at the end of the survey, you can see that we had a fairly dramatic shift towards opposition. And I would add that we did test the other side's arguments. So, we tested religious freedom arguments and other kinds of arguments. We tested, access arguments, sort of positing that, people can just go somewhere else. I mean, and the kinds of arguments that we've heard, and I've heard, in lots and lots of research I've done. So we didn't just test our messages and then re-ask how people felt about religious exemption laws. We tested their arguments too, and you can see that the movement towards opposition is quite powerful. And again, a lot of this has to do with the fact that people don't know a lot about these laws, and what they do know about, like Hobby Lobby, it's fairly superficial, and they certainly haven't connected the dots around what the impact is on patient care. And obviously, that's not totally an accident. The people who promote these laws don't want people to make those connections around what the consequences are for patient care. People these are hypothetical questions, but they're important ones when we ask about, if it would make you more or less likely to vote against, or for a member of Congress, depending on their views on exemptions. And what you can see is that overall, people lean towards being more likely to support someone in Congress who opposes exemption laws. It's not huge, it's 38 to 32. Obviously, most people say that it makes no difference, they don't know. A lot of people don't know a lot about the issue. But you can see if you look among Democrats and liberals and people who are pro-choice, that this is an issue that generates some intensity. And I think this is important because we have, and this can, the people who do the work at the National Women's Law Center and do the lobbying and the talking people on the Hill, there are people who are pro-choice legislators who are scared of these issues, right? And part of what we would say here with this research is that we shouldn't be, our champions, our pro-choice champions and even our, people who are pro-choice but not necessarily champions should not be scared of this issue. They should not be scared of talking about it, and that certainly the base of support for these pro-choice legislators are strongly opposed to these exemption laws. I do think that one challenge there's obviously plenty of challenges, but one challenge that we do face is voters' relative lack of awareness about the problem of access. And I think that, the argument that, and we tested this and talked a lot about it in the focus groups, we obviously want to make an argument about what this does with access, right? Because you think about Texas and other places, you think about places where it's incredibly hard to get an abortion anyway, and then you add this layer where there's hospital systems merging, et cetera, et cetera. But the truth is people don't really believe that there's an access problem. And you can see if you look at the left-hand side of the slide, when we ask, is it too hard, too easy, about right, don't know, you can see that 20% say it's too hard, a third say too easy, and the rest say it's about right or they don't know. I would submit that a bunch of those about right probably don't know. And even among people who are pro-choice, so in this case, people who said abortion should be legal under all or most circumstances, 41% say access is about right. And so we spent some time in the survey and the focus groups sort of priming people with information about access to see if our arguments against religious exemption laws could be stronger if people knew about the issues of access. And what I tell you is that they're not. When we tested, we provided people with information about access. You can see here, and we did a priming experiment where half the sample got the information about lack of access or challenges to access, and the other didn't. And you can see we did move people to, more people saying too hard. Okay, so if you recall from the previous slide, 20% said too hard. In the revote, 34% said too hard. But what we found was there was a lot of Democrats and pro-choice and liberal and college-educated women who moved towards too hard. So it was really a lot of people who said about right or didn't know, who really don't know. We didn't move anyone who was sort of in the middle or swing, on these issues. But more importantly, when we tested the messages and also tested the questions we re-asked, we did not find that the half the sample that heard anything about access did not perform any different. It had no impact. And in the focus groups, there was some real pushback, especially when we talk about access in terms of minority women. And even among minority respondents in the focus groups, they pushed back very hard on this being an issue that disproportionately affects minority women. They were more amenable to talking about low-income women, but again, real challenges around convincing people that access is a problem. Finally, I want to note that that there are some real, we obviously are playing a lot of defense on refusals and laws, but there's actually some proactive measures and policies that could be undertaken and are being undertaken that have pretty strong support, and that'll be discussed in a later presentation. But you can see here, making sure hospitals, doctors, nurses provide patients with medical services, including abortion. And we know we're being pretty careful to make sure abortion's front and center in these. This doesn't work if abortion's not part of it. You can see strong support, 60%, making sure a hospital that does not provide abortion still provides correct and complete information and referrals, 58 strong support. And even the ones that are weaker still have pretty intense support. So there is actually an opportunity here. We shouldn't be scared of taking on this issue. There's a real opportunity here to proactively try to ensure that women get the reproductive health care that they need. So, just sort of final considerations here. People really do oppose religious exemption laws, particularly when they get information about it. The refusal to cover or provide treatment, information, referrals in any way that interferes with patient care is outrageous to people. They think that people have a right to complete and accurate information about medical treatment. And they don't believe that individual, and I think it's really clear, individual religious or moral beliefs, which people know there isn't any one that there's the establishment clause, could interfere, with patient care, especially if it's patient care that's at least subsidized by some kind of federal dollars. And then finally, that there is an opportunity, I think, to talk to elected officials on these issues, and that our pro-choice allies who maybe aren't the activists shouldn't be scared to take on this issue. So with that, I will stop, and we're going to pass it on to Faith. I assume that control will be taken away from me and passed along, however that works. There you go.
My phone won't unmute.
Faith, I think we can hear you.
Can you hear me?
Yes.
Oh, good. My phone keeps saying that it's muted, so sorry about that. My name is Faith Grusbeck. I was working for public health in Muskegon County in the field of infant mortality reduction when a hospital merger left my county with a sole Catholic hospital that nearly every healthcare provider then worked for. So before the merger, there was a lot of community discussion about what this might mean for access to reproductive health care. There were meetings, people had to vote on it, and hospital officials reassured us that there would be no change in access. Well, they lied. I included my information here because I want people, if they are going through this in their community and they want to talk to somebody or they're interested in speaking out, I want them to contact me. So that's why I've shared my information. It's really important that people share their stories, because otherwise people won't understand how denial of care looks in reality and how it affects people in their everyday lives. So some people have come forward, and some of us have read those stories in magazine articles and online and in some of the reports some of the national organizations have done. But there are really good reasons why most people who are impacted don't come forward. First of all, a lot of these situations are very traumatic for people. So a lot of times it's hard to talk about some of our hardest, most difficult, painful life experiences, and that takes a lot of support and a lot of courage to be able to do that. So it's a good reason why some people don't talk about it. Also, these are stories about the most private aspects of people's lives. So their desire to have more children or not have more children is something that's very personal. Also, there's a high burden of knowledge that we place on people when we ask them to know whether or not they've been denied access to care. I've heard this over and over from people that it didn't matter that our only hospital didn't provide certain services because people can just go somewhere else. The people, especially in an emergency situation, are going to go to the nearest hospital. They don't necessarily know what the restrictions are and understand how they might be impacting their care at that moment. And that's a very high burden. I spent a lot of time looking into this issue, reading perinatal journals and figuring out what was going on and what the standard of care it was and why it wasn't being followed. So for the average person, they're not going to understand that. Also, in our community, nearly every health and human service organization is faith-based. So if a person speaks up, there could potentially be economic consequences to that. People don't want to lose their jobs, especially if there's only one provider in town. If they get in trouble for speaking up, they're going to have to pack up their family and leave and go somewhere else to find a job. Making it easier for people to report when their rights have been violated and getting better support for whistleblowers could go really far in helping people who haven't experienced discrimination based on religious healthcare exemptions understand the impact on those who have. So I would be happy to discuss that with anybody who wants to organize around better support for whistleblowers. Although it's been a hard time for me and it's scary sometimes to tell the truth, I'd never regret that I did. And I found tremendous support from people all over the country, and I've had a lot of opportunities that have come to me because of it. There's been a lot of attention around how miscarriage can be mismanaged under the ethical and religious directives that govern care at Catholic hospitals. So today I'm going to tell a few stories that are a little different that maybe you haven't heard before. These are all stories that people told me firsthand. The first one is a woman who works at a business that I frequent who told me that her first child was born by cesarean, and she scheduled a repeat cesarean for her second, and she had signed paperwork in advance so she could get a tubal. She was done having more children. And at the time of her surgery, there was nobody on staff who believed in sterilization to do the procedure for her. So by the time she had recovered, her health insurance, she was on Medicaid, had run out, and she could no longer afford to have the procedure done. The second one is a woman who was carrying a fetus with a known lethal anomaly. So the baby she was carrying was diagnosed with birth defects that were not compatible with life. And as is very common with some birth defects, she developed excess amniotic fluid. And toward the end of her pregnancy, this got so severe that she was in intense pain. And she went for days on end without being able to sleep. The pain was so bad, and eventually had hallucinations based on sleep deprivation. She eventually delivered on her own. And the last story is a story that a woman told me. I was presenting at a local college, and she came up to me in the hallway afterwards, and she said, "I don't want to tell the story myself, but I want you to share the story with other people." It was shortly after the hospital merger took place, and she had gone to the hospital ER. She was pregnant and had 2 children already and did not want to keep the pregnancy. She told them, "I just want to pee in a cup, get a prescription for an antibiotic, and go home." So when she told them that she planned to terminate the pregnancy, they called in a social worker, and the social worker lectured her that abortion was murder. They then told her that they would not give her a script until she had an ultrasound. Since the ultrasound was medically unnecessary, she was billed for it and had to pay out of pocket. The person who did the ultrasound printed out pictures of the fetus and handed them to her 2 children that were with her. Institutional policies that can restrict access to information about or prevent referrals to and deny treatment for essential reproductive health care services impact the entire community and make the prevention work of public health difficult, if not impossible. The majority, as I mentioned before, the majority of our health and human services providers require employees to sign a statement of faith to get a job in their organization and don't allow them to share information about family planning with consumers. So this goes far beyond the hospital to mental health care providers, service providers of all kinds, primarily those that provide services to families. There are also gatekeepers at government and non-religious organizations that use their position to restrict access to services, particularly family planning. When I was at Public Health, I coordinated and chaired our family planning task force for many years. And during that time, I ran up against so many barriers because of the situation. Call center staff would deny the inclusion of abortion providers in their database. It wasn't a policy, it was a person's decision. Government employees not allowing free condom distribution among items available to families in need. Other government agencies denying information on how to access family planning services for those who were uninsured because they were unemployed. Receptionists at federally qualified health centers incorrectly telling patients that their provider would not write them a script for emergency contraception. These are just a few of the many examples I could share. And despite these barriers, we were still successful in getting information and services to the public and reducing infant mortality. But when I started to realize that all of these barriers were so entrenched in these organizations, I suggested we create a survey for professionals to examine those barriers. Some of the questions were really similar to the ones in the presentation prior. And the Administration for Public Health eliminated the entire program because I brought that up. These denials of care disproportionately affect those who are most disenfranchised and have the least access to health care. They are also impossible to enforce or monitor. So that's one of the things that people who live in communities like mine realize, is that it's not predictable because they're implemented by people. And each of these people has personal biases. Health and human service providers can act in ways that make already existing inequalities worse. Since surveillance of infant and fetal mortality and the Family Planning Task Force have been eliminated, Muskegon County's Black infant mortality rate is currently the highest it's been in over a decade and the highest in the entire state of Michigan. It's the most sensitive indicator we have of the health of the community, and right now it's the most dangerous place to be born Black in the entire state, more so than Flint or Detroit. This is what religious restrictions in healthcare has done to my community, and it's completely unacceptable. Thank you.
Hi, everyone. This is Bridget Amiri from the ACLU. Thank you so much, Faith, for telling those stories. Are you able to see my screen?
Yes.
Okay, great. So absolutely, as Faith said, it's difficult to get individuals who have been harmed by the religious affiliation of a hospital or a healthcare entity to speak out, and there have been some brave people who have done so. And we've also found that when there have been those brave stories that have come forward, women who've told their stories, that other women have done so and have been inspired by their bravery. So just want to highlight that we've been collecting the patient and provider stories in situations where there has been a denial of health care from a Catholic hospital. And this is the report that we put out last year. And on the cover is Tamisha Means, who was denied care at the hospital in Faith Community in Muskegon while she was miscarrying at 18 weeks. She was, her water broke, she was in severe pain, she was bleeding, she presented at the hospital emergency room 3 times over the course of 2 days, and never was she provided information about her treatment options, namely that terminating the pregnancy would be the safest course for her. And eventually she delivered the fetus, which died shortly after because it was so early in the pregnancy. And at that point, Tamisha had also started to develop serious infections that could have been life-threatening as well. So we have collected the stories, and also there's some data in the report provided by Merger Watch, and also want to flag that Merger Watch is a fantastic organization that has done a tremendous amount of work on this issue as well, including providing the data for this report and putting out several reports as well that you can find on their website. 1 in 6 hospital beds right now are in hospitals that are governed by Catholic policy, and so that's also just important to keep in mind in terms of the prevalence of this issue. As Gretchen mentioned before, there are various tools in our toolbox. So one is litigation. There's state and federal court litigation that is ongoing right now or has been tried in the past using state and federal law. There is state and federal agency advocacy and public advocacy as well. And proactive state bills. As Gretchen mentioned, the country is blanketed with state laws that allow religion to be used as an excuse to providing proper reproductive health care, and in some cases, even from providing information or referrals. So one of the tactics is to change those laws. So I'll highlight a couple of examples. One is from Illinois, and Illinois has a law called the Healthcare Right of Conscience Act. And prior to January 1st, 2017, the law shielded refusing individuals and institutions from liability, such as medical malpractice lawsuits and discipline at the state agency level. So working in coalition, the ACLU of Illinois spearheaded the changes to this law and got an amendment passed. Basically that requires protocols to be put in place if the institution is going to refuse to provide certain services. Patients must receive information in accordance with the standard of care, and the provider who's refusing must refer, transfer, or give information about other providers reasonably they believe may offer the service. And they also must send medical records that are crucial to providing the information. And I put up a picture here of Mindy Swank, who was a woman who was denied proper care in Illinois. She was thrilled to be pregnant with her second child, but tragically her water broke at 20 weeks. And her doctors also discovered that the fetus that she was carrying had multiple anomalies that were incompatible with life. Bleeding and in pain, she presented at the hospital 4 times over 5 weeks, which did not provide her with even information about terminating the pregnancy, much less the proper services of terminating the pregnancy. And that's all because the hospital was bound by the ethical and religious directives that govern Catholic healthcare. She finally started hemorrhaging at 27 weeks when the hospital finally induced labor, and the baby died shortly after it was born. So the ACLU of Illinois talks about how, when presented with Mindy's story, certain stakeholders that would typically oppose an amendment that of the one that they were introducing were neutralized by Mindy's stories. And in fact, the ACLU of Illinois talks about how, after hearing Mindy's story, certain stakeholders, certain potential opponents felt like they had been punched in the gut after hearing Mindy's story. And Mindy's stories and other patient stories actually neutralized the local Catholic conference and other opponents. And so just to highlight how important patient stories are when doing this advocacy. I'll also just mention that there have been a couple of lawsuits that have been challenging the amendments that were passed to the Illinois law, but nevertheless, it was an amazing victory. Trying to advance slides. Here we go. So also want to mention that there have been proactive bills introduced in New Mexico, Michigan, and Washington. They have moved this session, but unlike the Illinois amendment, have not yet passed, but there have been some momentum. And these bills, what they do is ensure that healthcare providers are not prohibited from providing the proper standard of care or providing information and referrals. Because one of the themes that we see here is that individual providers who work at Catholic hospitals often want to provide the proper care and are prohibited from doing so because of the ethical and religious directives that govern the hospital. So the bills that have been introduced and the stories that have been told is that institutions should not be tying doctors' hands from providing proper patient care. And as the theme is here, that patients should be put first when it comes to the delivery of health care. Some of the bills also that have been introduced ensure that patients receive proper care when their life and health is at stake. I'll also just mention that there's litigation pending in California right now in California State Court on behalf of a woman who was denied a tubal ligation at the time she was delivering her 3rd baby at a hospital in Redding, California, and that hospital is owned by a very large Dignity healthcare system, one of the largest healthcare systems in the country. Physicians for Reproductive Healthcare are also in the lawsuit on behalf of its members, its doctors who work in Dignity facilities, who are prohibited from providing proper patient care because of the ethical and religious directives. And having your tubes tied when you give birth is the safest and most effective method of sterilization. And so Rebecca's story and other women who had been denied tubal ligation at the hospital in Redding really drove this lawsuit and drove our conversation about telling the story of patients who should receive the proper care, and regardless of what hospital they go to, and they should receive information. And also physicians who want to provide the proper patient care should not be prohibited from doing so because of the hospital's religious beliefs. And from there, I'll turn it over to Yamhi for questions.
Thanks, Bridget. So thank you so much to our speakers today. At this time, if you have a question, please type one into our chat function and we'll make sure that it gets answered. And as a reminder, we are recording today's webinar, and we'll send the webinar recording and slides around to everyone within the next few days. Um,
And Yumhi, this is Gretchen. Sorry, this is Gretchen. Can I just jump in before we start doing questions? I'd like to ask Anna to talk a little bit about the state oversampling we did and the findings in those states. So if we can start with that, and then we'll see which questions come in from there. Thanks.
Sure thing, and I apologize for not mentioning it during my talk. We did state oversamples as we mentioned when I first presented the methodology in 4 states. The oversamples were in Michigan, New Mexico, 3 states: Michigan, New Mexico, Virginia, and Florida. And first of all, there really were very few differences. I mean, and there were very few differences on the core measures, and there were no differences on the ranking of the messages. And so I think it's important to note that, across the different geographies where you all are working, that there aren't really serious distinctions. The one thing I would say is that the states that have higher minority populations tend to be even more supportive of our position. We see in this research, and I've seen it elsewhere, is that minority voters are more pro-choice than white voters, and minority voters in this research on all these measures were stronger in their opposition to these religious exemption laws. And so in New Mexico, for example, which is a large Hispanic population, the results were sort of even better, if you will. But that was really the only difference, was that in Florida and New Mexico, which have significant, I'm not suggesting Virginia and Michigan don't, but as a proportion of the state, the higher proportion of minority voters led to even more support for our position.
Great. So we have a couple of questions coming in. There's one that says, is there any data about being denied care from a non-Catholic hospital?
This is Bridget. I don't believe that there is that data, and I can just tell you anecdotally, the stories that we hear from denial of care is overwhelmingly from institutions that are following the Catholic ethical and religious directive.
This is Gretchen. I would just add to what Bridget's saying to say I think we've heard anecdotally of some circumstances where there are different religious beliefs cited. They aren't necessarily Catholic hospital or a Catholic provider, but I don't know of data that's looked across that, across the board. Next question, Yumhi.
Great. We have another question from Katie. Are there any legal protections for women in states that have not passed explicit protections against religious refusals?
So, Bridget, why don't you start by talking about some of the protections you've used in some of your lawsuits?
Sure, and then Gretchen and anyone else can jump in, but definitely yes. So it really depends on the state in terms of what's available at the state level and the interplay between any refusal law that's on the books and medical malpractice law, or sex discrimination law is another tool that can be used at the state level. I'll also mention at the federal level, there's a law called the Emergency Medical Treatment and Active Labor Act, EMTALA for short, which says that any hospital that operates an emergency room and that receives federal funds, which is pretty much every hospital that runs an emergency room as far as we know, must stabilize patients when they're in emergency. And there is no exception for an abortion. So if a woman is in an emergency and she needs to be stabilized, and the only thing that's going to stabilize her is an abortion, then the hospital must do so, otherwise they'll be in violation of federal law. There are also protections at the federal level for sex discrimination as well. So yes, there are tools in our toolboxes, tools in the toolbox that would offer protection, and it just depends upon the denial of care, what state you're in, and things like that.
Thanks, Bridget.
Great.
Next question, Yumhi.
One from Sam. Has any research been done on religious refusals by disability service providers, such as group homes or home health aides for people with disabilities? These service recipients have extremely limited options in terms of finding care from other providers, since often faith-based providers are the only ones in the region.
That is a great question. Faith, have you heard of any of those types of refusals or problems in your community?
Not specifically, no, I haven't.
Okay.
But it also isn't my field, so I wouldn't necessarily have access to, those stories.
Okay, thanks. Bridget, have you heard of that?
I haven't. I haven't.
Okay. Well, we have heard from other kind of disability rights groups that it's certainly come up for them as a concern, and I think we heard of one example, but haven't heard of it across the board. But it also may be true that, again, what we heard from Faith is that sometimes people don't realize that they're being refused something. They don't necessarily either know that they have the right to get certain treatment or get a referral or information. And so it may be that people aren't realizing it, or that they aren't aware generally of the problem of religious refusals to provide care. And that's part of the reason we wanted to do this survey, to use it as a tool, not only to educate the groups that are doing this work day to day, but also others that it might touch. And I think we've already started to try and reach out to some more non-traditional groups that we think are touched by religious exemption laws, and would love to do more work. So if the person who asked the question has inroads to those groups or thinks there are partner organizations that might want this information, we would love to get that to them and have those conversations. So thank you for raising it. Next question, Yamhee.
Next question is, was the polling of women only or the general population?
Anna,
the general population. Yeah, it was registered voters, general population, representative, random sample. So it was not just of women. Not surprisingly, women are slightly more pro-choice than men, but overall their attitudes on this don't differ all that much, which is pretty consistent with what we know about attitudes about abortion rights, is that there are not huge gender differences.
Thanks. Next question, Yamhee.
So those are all the questions submitted so far. We encourage folks to continue to submit questions that you might have by typing it using the chat function. Gretchen, were there any questions that came up during the briefing that we did on this that you want to address?
I don't think so, but I do want people to know that, we at the National Women's Law Center are here as a resource. If you want more information about the polling, or if you have follow-up questions, we'd be happy to answer them. If there is a venue that you think this information would be helpful to present at, we would be happy to do that. In particular, we want to try and start getting this out more broadly to states and state policymakers to try and push them to do some of the good proactive policy solutions that Bridget talked about. And so, we're interested in partnering with state organizations to do that work. So just, we're here as a resource. We want to be able to make sure that this research is helpful to everybody who's fighting against the use of religion to, override patient care or to really harm individuals, which we know, unfortunately, has been used more and more to do.
Right.
Any other final comments from any of the presenters?
We actually have one more question by Amy. She asks, do the conscience laws you cited affect pharmacists?
So some of them do, yes. Again, you have to look kind of state by state. And so in some states, they define healthcare provider or individual very broadly, and it could include a pharmacist. On pharmacy refusals specifically, there's actually been a lot of work in the last number of years to push back against that, and a number of states have stepped forward to pass their own proactive laws. Another good example of states stepping forward to say, patient care should come first, and telling pharmacists, you can't refuse. You have to make sure that an individual leaves the pharmacy with that prescription that they need. And so usually what we saw was the state would say, okay, even if an individual pharmacist wants to refuse, somebody else in that pharmacy has to take care of that patient. So the patient got the care they needed. So that's a really good example. And I think, again, it's kind of a state-by-state question of whether or not a pharmacist can or has a right under one of these types of religious exemption laws. But of course, that kind of law could conflict with a pharmacist's other obligations and duties. And we did a lot of work to point that out, that even if a law tried to give that pharmacist that right, they have other obligations and duties under pharmacy law and their obligations. So it's a complicated question, but certainly another area where we've seen religion cited to override patient access to care.
Great. I think those are all the questions. Do presenters or speakers want to give any last final thoughts?
Okay, well, thank you all so much for joining us. We really appreciate you taking the time to hear this research. And as Yumhi said, we will be sending out a follow-up email with the survey results and other resources. And we hope that it will be useful to everyone moving forward to make sure that religious beliefs do not override patient access to care. Take care, everybody.